All right, so now you're, 7+ months into it. So how has that gone for you, moving from that pediatric system to the broader adult system?
It's definitely been a steep learning curve. I'll tell you a story about my first couple of weeks in the role of CMO. So we have a very busy coronary care unit in our hospital, and we had just made some significant investments in our cardiology service line. And we had some questions come up about impellas. And I went to medical school in Canada in the 80s, and I had absolutely no idea what on earth they're talking about. I thought it should be an animal I should be seeing on a safari. And I really took a while to get myself oriented to what impellas are.
Hello, and welcome to the Fire Chief Podcast, the only podcast dedicated to the Chief Medical Officer. I'm your host, Lee Scheinbart, and this podcast brings you the hottest and most crucial conversations in healthcare and physician leadership. Today's guest lives in a small place known as Princeton, New Jersey. When I was about 2 or 3, my parents moved to a place known as East Windsor, which is about 10 miles away from Princeton. What a small world, right? But later, we moved far away to the Buckeye State, the great state of Ohio. But what our guest ultimately did with his career was move about 1 million miles from one location to another, almost from one planet to another. And I'll explain that in a moment. Today's guest, Dr. Harpreet Pall, a highly educated, well-trained, and experienced pediatric gastroenterologist, had just made one of the most profound moves that a physician leader can make. He has moved from the world of pediatrics to the enormous ecosystem of adult-based hospital management, full stop. Dr. Pall, the recently appointed Chief Medical Officer at Hackensack Meridian Jersey Shore University Medical Center and at the Hovnanian Children's Hospital, grew up in Montreal, Canada, and earned his medical degree at McGill University. He went on to complete his pediatrics residency at Memorial University in Canada, before completing a fellowship in GI from Harvard Boston Children's. In addition to being a CMO, Dr. Pall still sees patients and serves as academic chair and professor in the Department of Pediatrics and chair of the faculty assembly at Hackensack Meridian School of Medicine. Dr. Pall has significant formal management and leadership training, having participated in a year-long leadership fellowship in Boston and later earning his MBA from the University of Massachusetts. He went on to participate in a dean's internship at Drexel University in Philadelphia, and at nearly the same time received his Certified Physician Executive designation from the American Association for Physician Leadership. But none of that can actually prepare a physician to switch from the world of pediatrics to adult hospital medicine, and we are about to hear much more about that on today's show. So Dr. Pall, welcome to the show.
It is such a pleasure to be on this show with you, Lee. So thank you so much.
You're very welcome. I think we're going to hear something that we've not discussed on this show, and it really is that big switch. And I'm wondering if maybe you're starting to second guess your decision to be on this show. I mean, not everyone makes this kind of move, and we're going into some uncharted territory. So we can consider this like an endo suite timeout. We can call this the podcast timeout. Are you still willing to do this with me?
I'm all in.
Great. All right. So as I understand this, you have served in a variety of academic and medical staff leadership roles, and now most recently, Chief Medical Officer. So I want our listeners to hear a little bit about how did you make that bold decision and why this particular role?
Thank you so much, Lee, for that question. Been a very interesting journey for me. So first, as you said, growing up in Canada, seeing the Canadian healthcare system, doing my residency in Canada, making the move to Boston after that, thinking I was always going to go back to Canada, but ultimately just a lot more opportunities in the US after I finished my fellowship, and I decided to stay at Boston Children's for a period of time. My career always has been in the past, historically, in academic medicine, especially related to pediatric GI. That's what I trained to do. That's what I thought I would do my entire career. And as I took on progressive leadership roles, becoming a chief of the GI division next, and then a chair of pediatrics, it's really, stepping outside of the GI world, firstly into a broader pediatrics arena was a transition for me, looking at specialties outside of GI. So, for example, it's not just the colon, there is such a thing as a heart and a brain, and you have to pay attention to that as well. So, that was a bit of a transition. But as I moved to New Jersey from Philadelphia, and as I joined a hospital and a health system that has multiple hospitals, Hackensack Meridian Health, I got exposed to broader healthcare. I came from independent freestanding children's hospitals now to integrated matrix health delivery systems. And getting exposed to that broader aspect of healthcare really ignited my passion that I want to improve health for all patients, not just specific segments of ages. So, an example of what really solidified in my mind making that leap into a broader healthcare leadership role was attending our safety huddles at the hospital. We have a culture where we have a daily safety huddle in the morning where all departments, including our children's hospital and the adult departments, report out. And being involved in that huddle, seeing the impact of engagement and that culture of safety and high reliability that we're implementing, that exposure really solidified in my mind that I want to make a broader impact. I want to engage on a different level. And a CMO will allow me that opportunity to really be a partner to the medical staff and to help achieve our mission for everybody that we serve. So that's one of the factors that led to my applying for that CMO role when it did become available. And I'm very happy that I'm not looking back. So thank you for that question.
Oh, you're welcome. Yeah. Safety huddles are very common nowadays. They were not necessarily back when I was a younger physician. And seeing the breadth and the depth of hospital operations right in front of you, I do understand what you're referring to. And many of our listeners want to take on, look, we're wired as physicians. We want to fix stuff. We want to do stuff. And then we see something that we might not have seen in our earlier education and training. And then we're like, I can do this, right? And so that's what I'm picking up from you. Does that sound fair?
Definitely.
Okay. All right. Well, so now we understand about what you were thinking, but at the same time, right, this is a big leap. And you and I spoke earlier, and obviously one of the key things moving from a practicing academic physician is to develop leadership skills. And you've spent a significant amount of time in leadership development programs. So maybe you can pick one or two or three takeaways from these programs that have stayed with you throughout this journey. Maybe give some pearls to those who have not yet taken this step.
Yeah, I do believe strongly that leadership skills can be taught. And I'll share with you two examples of skills that I use to this day that have really helped me along my journey.
Let's do it.
Yeah, the first is that skill set that I call meta leadership. And that's where you have the opportunity to bring together different perspectives of maybe it's a conflict. And for example, we had a scenario where I was recruiting for a senior physician leadership role, and we had differing opinions of what that candidate needs to look like and ultimately who we should decide on choosing. So by bringing these differing perspectives together at a table, by setting some ground rules about a no finger pointing environment and the opportunity for each one of these stakeholders to have their opportunity to present their perspective, we can understand that sometimes the scenarios that we're looking at are not black and white concrete decision points, but they're really multidimensional issues and challenges. And by hearing each other out in a constructive and facilitated manner, people can understand ultimately the best decision that needs to be made. So that meta leadership approach, I think, has served me well. The other skill set that has been really helpful to me over the last couple of years is something called forced engagement. And it's been especially important during the COVID pandemic with our transition to virtual meetings. It used to be that sometimes as I was leading meetings and discussions with our groups of physicians, that if there was a question I had, or if I wanted to ask if the audience had questions that I would say, hey, do you guys have questions? Let me know what more I could help clarify. And you could hear a pin drop. Not a single person would speak up. But what I found really needed to happen in those scenarios is for me to actively engage the audience by calling them out by their names and making sure I did that with each and every person so that all of them had the opportunity to speak. It's amazing to see how alive a conversation can become when you use that. And I think it's also important to treat it as a conversation rather than a didactic me presenting something to them.
That's great. Yeah, meta leadership involving people, getting all perspectives, building consensus to the extent that you can or need to. But sometimes it's just that act of listening. I don't mean active listening. That is a learned skill that we probably pick up in medical school anyway. But it's the act of listening, really deliberately bringing information into one's brain or making sure other brains are hearing that information. So that effective exchange will go a long way. So when we spoke along these similar themes, you were concerned once upon a time about that movement from the pediatric ecosystem into the adult system. All right, so now you're, 7+ months into it, and you knew your vision was to have an impact on healthcare and hospital management, but there's still that question mark in your mind. So how has that gone for you moving from that pediatric system to the broader adult system?
It's been overall great. It's definitely been a steep learning curve. I'll tell you a story about my first couple of weeks in the role of CMO. So we have a very busy coronary care unit in our hospital, and we had just made some significant investments in our cardiology service line. And as I'm getting adjusted to the role, we had some questions come up about impellas. And I went to medical school in Canada in the 90s, and I had absolutely no idea what on earth they're talking about. I thought this should be an animal I should be seeing on a safari. And I really took a while to get myself oriented to what impellas are. And, it's actually fascinating. And I was so impressed by, what we've done over the last 2 decades. We're 5 in. So that's, it's been a great learning journey getting used to the metrics that we're using in the adult world, like, let's say, readmissions, discharge to home, things that were a little bit more tangential perhaps in the pediatric world. But just immersing myself in that data has been truly pleasure, and it's been fascinating. And I believe that I've gotten well accustomed at this point that it's a steep learning curve and a very adaptive, intentional change. So it's been overall great. And I would say also that even though the worlds might seem quite different, the competencies and the themes are actually very translatable from pediatrics to adult medicine. As a pediatric chair, I was overseeing 20 different service lines. As a CMO, the ages are different, but again, it's that oversight into a lot of different specialties and services. It's learning a new vocabulary. It's leading and engaging in a broader way, but the competencies and the themes in healthcare are all very, very similar.
Yeah. So I failed to really articulate to the listeners. So not only did you move from pediatrics, but you moved from one country to another. And although we're both English speaking to the extent that there's a lot of French spoken in the Montreal and the Quebec area, yeah, the rules and the regulations of adult medicine are probably much more voluminous than in the world of pediatrics, primarily because of the payer structure and what CMS decides. Now, plenty of children are receiving Medicaid as their payer source. It's just that the rules and the concepts in the adult world are very nuanced. And to your point, it's about being a leader and leading, and you obviously are a natural and curious individual and a natural with an academic bent to learn things, but you cannot learn every detail in these roles. It comes over time, But if you spent all your time reading about every case law relative to EMTALA, you'd get nothing else done. And you'd still think it's some animal in Africa at some point because it's so bizarre, right? So I think you bring up some good points, whether you knowingly did it or not, about the role of leadership. And it's really kind of to pull up a little bit and kind of see the broader landscape and see, again, the perspective, how it was done in this country or this specialty or this part of the hospital, and get a different view. Let's go back to those beginning days a little bit more. The first 90 days, right? That people always talk about the first 90 days, and you and I talked about it. Maybe you could sum it up in either one word or one sentence, what your first 90 days were like, and then we'll explore after that. So what was your first 90 days like for you?
It was intense. That was
Intense.
an intense transition. I'd say a couple of things really helped me in those first 90 days. And there were a few books that I read to get me oriented better to what that transition was going to look like. And you're familiar with, I think, all of them. There was yeah, I mean, you've actually been hugely helpful in your show and the American Association of Physician Leadership, because the books that I read were I Want to Be a CMO, Now What? So that helped me help validate for me that this was a transition that I truly wanted to make. And as I started to prepare myself for that first 90 days, I read the CMO's Essential Handbook. So that really helped me understand all the aspects of the competencies and the content that I would need to be successful in the role. So that way, as I entered into that role on day one, I had a broader understanding of the areas that I would be expected and asked to lead in. And I think that was immensely helpful. And what I'm doing right now is I'm reading your really very well-written book, the CMO's Financial Primer. So I'm about halfway through it, and it's been very, very helpful to see the historical journey of our payment system, over the decades. So I'm really curious to see what the second half of the book is going to
Well,
do.
thank you. I mean, we got to be careful here because if all Canadian physicians read it, they're never going to want to come south of the border when they learn about how our system takes care of itself. So
yeah, it's both countries have very, very different systems, and one is not necessarily better than the other. There are just pros and cons of both of them. It's not
yes,
like either way.
I agree with that entirely. I think at some point when I have built up 90 episodes, maybe we could also suggest to our listeners that they could, for the 90 days prior to taking the role, they could listen to an episode a day, or each day of their first 90 days, they could listen to an episode, because there's a lot of stuff packed in these shows that nobody ever talks about. And so that's what we're doing here. So thank you for being a part of it.
Definitely.
So, all right. So it's intense. You're a reader. You're curious. You're a learner. We've established that. Was there anybody around you that either you reached out to or they suggested to you, look, I have some ideas that maybe you haven't experienced about, and you have been in other roles, right? But this was a step up. Here's how you go about your first 90 days. And then after, I'll tell you what somebody told me. Was there anybody who did that for you and what that was like?
Yes. So the president and chief hospital executive, Vito Buccellato of Jersey Shore University Medical Center, was really a guiding force as I was trying to be intentional about my transition into the role. So what I did was I created a draft outline of how my first 90 days was going to look like, and I put it into different phases. So the first month, the second month, the third month, and we worked on that together before my transition into the role. And what he also did was help with my orientation. So the first few weeks, he had scheduled a lot of meetings with different stakeholders throughout the organization and the network. And he had a lot of support from other leaders in the hospital and throughout the network as well. So I think that level of support was critical. What we also did was we had the incumbent in the role at that time before I had transitioned into it, Dr. Kim Carpenter. He had been in the role for years and has been incredibly experienced, and actually stayed on to help me, for some time after my transition into the roles. Having that time with the with my predecessor in the role was really helpful to give me a better understanding of, why things are the way they are. How did they come to be in this particular manner? I think that was very helpful to ground me. What I found really helpful as I transitioned into the role was to really get to take the time to meet with the medical staff in person and go to their place and go to their office and don't have them come to me, but just walk around and get to know the hospital and just walk everywhere and meet people, understand what barriers they have, what's going well, where we have an opportunity for improvement. I think that developed some credibility upfront, which was really important. So just being curious about how we can help and work together to improve patient care. That credibility in the first 90 days, I think, has translated to having a more grounded, first year in the role. So that was really, really important. Taking the time to listen and to meet and connect is hugely critical, and being intentional about it. So I was very intentional, rightly or wrongly, and I had a very methodical way about going about it. Perhaps I had read that book the first 90 days, and it kind of stuck with me because I've had a number of career transitions over time. So that's what I did. Those are the mentors that I had as I transitioned into the role. And in hindsight, I think that was a good approach.
Yeah, I totally agree. I too was offered and suggested, and I took the offer of a more formal, what they called for me a formal 90-day plan. And that's exactly what you described. And then we had a series of 90-day plans for my first year so that we're always moving in a particular direction. And I like the way you framed it. This is how I want these days. This is what I want it to look like, not some kind of arbitrary thing that's pulled out of nowhere. So I think that's a very wise approach. One thing that you said, and I'm curious, baked into what I'll call the 90-day plan, were you instructed to meet the medical staff leaders, or advised, I should say, or was that something you came up with on your own?
It was part of my structured plan. So meeting with the medical staff office leadership and meeting with the members of the MEC, as an example, was part of the way that we had structured the orientation.
And I'm going to go a little bit deeper because I think this is an incredible pearl that we've never talked about on the show, especially if you have moved from one institution to, so you're new, you didn't practice with these guys and girls for 20 years, right? Did you go to their offices or their pre-op holding or their suites, or did you make them come to your office, so to speak?
No, I went to their place because the optics of this is to me, it was very important that I wanted to be seen as a partner. I wanted to have credibility. I wanted to have trust in the relationship. And, trust takes time to build, and it can be broken, as all of us know, very easily. And by me taking the extra effort to get to know them in their place and getting to see them and their teams, take care of patients where they are, to me, that was important, and that would be the right optics for what the CMO really, really is, which is, ensuring that our physicians have the right tools and environment to be successful.
Yeah, it is. I also believe, knowingly or unknowingly, you make them feel honored, validated, heard. And so many physicians today don't feel like people are listening to them. And so, yeah, I would advise anybody out there who hasn't already considered this, if you're stepping up, whether as a service line leader, medical director, all the way to the CMO and these traditional roles that we're talking about, give equal weight to meeting with the chief financial officer, your HR partners, your operations people. Give equal weight to sit down with medical staff leaders, both formal and informal, titled and not, on their turf. Go out of your way, schedule it, make it happen, bring them a cup of coffee if they like, something like that. I think those are invaluable ways to begin to build the relationship, which is sort of a starting point, right?
I totally agree.
Yeah. So is there anything that you would have done differently in your first 90 days? Anything you feel like you could have changed?
Yes. So I wish I had more time to breathe and take a breath and just reflect on the conversations and the learning that I had going on, because in hindsight, looking back at the way that I had organized my schedule. It was really me that was trying to understand and learn and get up to speed as fast as possible so I could start adding value as soon as possible. So I had that internal pressure that I wanted to absorb it all so I could actually start making some decisions that might help advance our mission. But it's really, really important, especially in this role, that there's time to reflect and to think so that I can contribute to the development of a helpful and coherent strategy. Because if I look back at my schedule, I did not have a minute, and it was fairly intense, a lot of learning, building out or carving out some time on your schedule. On my schedule, I think in hindsight, might have been a good thing. So that's something I wish I had done a little bit differently.
So during that moment of onboarding and those first 90 days, who managed do you have an executive assistant?
I do, yes.
But were you looking over their shoulder to make things on the schedule, on the calendar, or they were looking over your shoulder?
It was probably a mix of both. And as I was transitioning into the role, I'm familiar with all of my direct reports. So in our hospital, we have the academic chairs that report to the CMO, as well as quality and safety and the medical staff and a few other areas as well. So it was a combination of both that I wanted to meet with certainly all of my direct reports and the teams that I would be supporting. And I did instruct my executive assistant to make sure that, we try to get to all these teams, and I want to attend their staff meetings. So I placed a lot of pressure probably on her as well. So it is what it is, and that's how it unfolded. So now I'm more deliberate about my calendar and how I organize myself so that I could stay focused on, what's really important and what's really meaningful. But that was a learning curve for me as well, as just how do I get myself organized to add the most value in the best possible way.
Yeah, when I go around the country and teach or have people from around the country come to where I'm at to hear what I have to say, which always amazes me that people want to hear what I have to say. But putting that aside, they loved our session on calendar and time management. And it was a light bulb moment for me, because as our education goes from the UME world to the GME world and so on and so forth, especially in the practice world, there are other people, mostly meaning our patients, that dictate our time. They need to be seen. They need to be taken care of. We need to do our workups. We need to round on them. We need to put them through the procedures. And we don't think much about control over our schedule, because it controls what we do, especially on a busy clinic day where, everybody is set up to be seen. And so when we become an executive leader, manager, there's a tendency, and I'm not accusing you of anything, of filling up the calendar of activities, because we assume activity is productivity. And they should never be confused. To be productive in this role, you have to have that white space time, that reflective, not at 10 o'clock at night when your brain is dull. It is. It just has to be during the day for maybe an hour here or an hour there, and not a 20-second lunch where you're trying to think of all the problems of the morning and all the problems that are going to surface in the afternoon. You agree with me, I can tell.
I definitely do. And, the challenging part of the role is that there's so many fires, as you well know. And it's so hard to predict your day on a day-to-day basis. You can plan all you want and, and then it is what it is. But I definitely agree that being intentional about how you spend your time is absolutely crucial to this. You have to have time to reflect and to develop your strategy for the meetings that you want to have and you want to hold. And also you have to have some time built in for the fires, because as you well know, that if you're fully booked with meetings and then the inevitable fires that pop up throughout the day, when are you going to deal with them?
That's right.
Cancel your meetings. And, so it's just not the right message that I want to send to people by scheduling things and then rescheduling.
Yeah. And sometimes it's not, and you're right. And that's why we call the show the Fire Chief Podcast, because you become a firefighter until you're the chief and one day you're the marshal. But at some point, you have to have sort of this available time on your calendar. And if nobody needs you, that's great reflection time. But if somebody needs you, and it might not even be as much a fire like something went sideways, but somebody needs you, and it's critically important that you take a moment to listen to them and that you have that on the calendar. Yeah, you are speaking my language, and I am totally in agreement with you. One of the reasons we launched this podcast was to share this stuff. Okay, so I'm gonna hit you with two lightning round style questions, and then we're gonna get to wrap this up. You have earned both an MBA at UMass and your CPE through the AAPL program, as we mentioned in the intro. I want to hear your thoughts on how each of those credentials or degrees helped you or not in your current role. I have some new thoughts about this, but I want to ask you first, how did each one of those help you or not help you in today's role that you're in right now?
Both of these experiences really contributed in somewhat different ways, although they're related. With my MBA that I completed back in 2017, at that time, it really helped give me the tool set that I needed to understand finance better and to speak that language with our finance administrators at the hospital I was at that time, and also get some credibility with them was really important. I remember I really enjoyed our sessions on strategy through the MBA and organizational dynamics. Those were things I really enjoyed. And I think what's really helped me as a CMO through the MBA was really the more so, I would say, the finance part of the competencies. The CPE really important because in these leadership roles, with all the change that's happening and the adaptive change that a CMO is expected to lead, it's not so much the hard knowledge about finance that's going to make a CMO necessarily very successful. It's the ability to drive change. And as you've correctly, very adeptly pointed out in your podcast, the CMO is the chief change management officer, essentially. So that competency to drive change, to lead physicians through a time of tumultuous change is critically important. And the CPE and its ability to help me engage physicians to develop an inspiring mission and vision, to communicate effectively, and to ensure that what I believe our physicians need, I'm able to pitch effectively to our health system. It has been really, really important. So having the competencies to know what needs to happen to move a project forward, but having the communication ability to pitch it effectively with passion so that it's heard and understood, and I'm able to express the why behind it is crucially important. So I'd say that both have been important and they're both complementary.
Yeah, I agree. The MBA is a great tool by which you learn finance and management language that you don't know, just like a non-clinician might not know, the language we use as physicians practicing medicine. So it gives you the language, but the CPE teaches you how to use it and lead, especially physicians. And yes, I naturally concur with you about change management and leading physicians through change. An MBA may not quite give you those tools for your toolbox, but the CPE will. So yes, complementary and helpful, but you don't always need both of them. And a lot of that depends on the student learner and what they want out of their career. Okay. All right. Next hot button question. What are you most afraid of right now as a physician leader, either for yourself or in New Jersey or healthcare in general? I mean, what keeps you up at night? What are you afraid of?
So I'm going to start with a story. And as you know, I've been a practicing pediatric gastroenterologist now for 20 years. And I'm going to share with you briefly a story of one of the first patients I took care of. Her name was Maya. This was back in Boston. And I was working with our liver transplant team at the time. And Maya was unfortunately born with a condition called biliary atresia, which I'm sure many of your listeners are familiar with.
Yes, but for our non-physicians, just like we spoke about language, explain what biliary atresia is.
So biliary atresia is a condition where the biliary system in the liver does not form effectively in babies. Usually it starts happening during pregnancy, so it's before the baby is oftentimes born. And as a result of the bile not draining properly, the liver can get scarred, and over time there becomes a need potentially for a liver transplant unless there's some corrective surgical steps that take place early in life.
Thank you.
Yes. So Maya was born with biliary atresia, and she was diagnosed early. She had an attempt at a corrective surgery called a Kasai procedure, where the intestine is brought up to the liver to help the bile drain out of the liver into the intestine. And unfortunately, that surgery did not work. Now, Maya's family came from a very poor background. They didn't have a car to get them to their appointments. Their insurance status was very, very challenging in the beginning. And also the literacy level was challenging sometimes for the medical teams to be sure that they were communicating in a way that her parents really would understand and retain. So Maya unfortunately needed a liver transplant. And I remember at that time, our transplant surgeon called me up and asked if I wanted to participate in harvesting the liver and then transplanting the liver for Maya. And I was absolutely passionate about being involved. I remember very clearly it was my first time getting on a helicopter to go and participate in the harvesting. Unfortunately, after the transplant, several months later, Maya died. And she died from CMV, which is a viral infection that oftentimes patients who get a transplant and they're immunosuppressed can unfortunately develop. But what that experience showed me is that how important it is to be proximate to your patients, to be connected to them. I was talking to Maya's family very, very regularly, sometimes even multiple times a day. But that ability to be proximate is so important as a physician. Really, at the end of the day, the patient, the doctor, and that relationship between them. And what I'm seeing right now in healthcare is a dramatic amount of change. We have external change, internal change, turnover around the country, and a lot of newness injected into the system. And now with AI and the disruption that is about to happen through that technology, what I'm most worried about is how are we going to ensure that that physician-patient relationship is paramount in all of this? Because I'm sure as your listeners have seen, sometimes what we end up with are solutions that we have, and we're trying to find problems to implement those solutions into. Whereas really with all these tools that we're having now, we need to build the solutions based on the problems that we have. So I think to your point, the risk of commoditization of healthcare, of losing sight of that true core purpose of what we're all existing for here. We all have a role in that, and we've got to, as physician leaders, ensure that that's our core purpose, that's our why, and that doesn't get lost in translation through all of this.
Very deep, very profound. And look, there are plenty of our medical students back 30, 40, 50 years ago that were not ever going to be great relational people. And that's still true today, and that's fine. I mean, there's no perfect model. But as a focal point, a vision, a true north of the house of medicine, there ought to be just enough of us, 51% of us, who believe that relationship is paramount. And yeah, sure, maybe the surgeon, we'll pick on surgeons for a second, not always the greatest with bedside and relationships, but they feel every case, and they take all those things home with them. I have some great friends that are surgeons. They don't outwardly express it the same way that others would. And so if it's not the surgeon, it could be the gastroenterologist on the team. It could be the oncologist or the nurse practitioner on the team. Somebody who can make that relationship the centerpiece of what we do for other people, along with everything else you mentioned that still has to get done. So very profound, and I thank you for sharing that. I hope you get some sleep tonight now that you got that off your chest a little bit, and that you continue to drive those changes to make sure we're getting that peripheral distractive junk out of the way, get rid of the stupid stuff, right? Gross, and get down to what is important, along with the important stuff at the same time. Any last comments before we wrap up? This has been a great show.
It's been truly a pleasure and a privilege. And I think the CMO job is the best job in medicine. So it's been a lot of fun. Thank you.
You're welcome. And I have many colleagues that would agree with you. Well, thank you for being on the show again. You've been listening, everyone, to the Fire Chief Podcast, the only podcast dedicated to the Chief Medical Officer. Want to learn more about what it is like to be a CMO? Listen, check us out on the website, thefirechiefcmo.com, and connect with me on LinkedIn. I love talking with CMOs and especially Canadian pediatric specialists who want to take on the United States and the world. So get out there, be a chief, and in the words of Sergeant Phil Esterhaus, let's be careful out there.